Welcome everyone to Grand Rounds. We have an exciting presentation for today. I'd like to begin as usual with our land acknowledgement to remind us that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So now I'm delighted to present our favorite colleague and friend, Dr. Stephen Freedman. Dr. Freedman is Professor of Pediatrics and Emergency Medicine at the University of Calgary. He completed his residency at the Hospital for Sick Children and a Pediatric Emergency Medicine Fellowship at Children's Memorial Hospital. He went on to obtain a Master's of Science in Clinical Investigation at Northwestern University. He interrupted a long lineup of CHEO-based chairs of Pediatric Emergency Research Canada to become chair of what we know as PERC. He is now past chair, and he is also the Alberta Children's Hospital Foundation Professor in Child Health and Wellness. And as an emergency physician, I really like that title of Child Health and Wellness. That's great. His research focuses on applying clinical research to improve outcomes in children seeking emergency care. His focus is on the use of innovative multidisciplinary approaches to solve complex problems. He has published over 200 peer-reviewed manuscripts and is the principal investigator on numerous multi-center clinical trials with funding support from CIHR and NIH. Most recently, he received CIHR funding to lead several multinational pediatric COVID-19 studies and NIH funding to evaluate an intervention to prevent progression of disease in children infected with Shiga toxin producing E. coli. The title of his presentation for this morning, and this sounds like a pipeline we can all support, the Pediatric Emergency Medicine Energy East Pipeline, Delivering Knowledge for Canada's Children. With that, turn it over to Stephen. Over to you.
Well, thank you very much, Dr. Jabbour, and it's great to see so many familiar faces, although I've seen many of these on Zoom over the last couple of years. Had been obviously fingers crossed that we'd be able to be in person, but we're getting there. Yeah, I kind of went with a bit of a cheeky title because, as we all know, the original Energy East Pipeline didn't quite deliver, but I do think that in the pediatric emergency medicine world, actually, we've been doing quite a good job of delivering knowledge to improve the health of children. So I just thought I'd get a little bit more interesting than the usual at 6:30 in the morning for myself out in Calgary. I do need to disclose that I receive in-kind support from Bibliometric for device diagnostic testing, and I do consulting for Red Hill Biopharma and Eligo Bioscience on therapeutics that I will not be discussing today. So, as we all know, the Energy East Pipeline was supposed to go all the way from out west to out east, and then there was a new pipeline going all the way to St. John's. Unfortunately, that never came to fruition, but along the way, there's the two hospitals, the Alberta Children's out west and CHEO out in the kind of east, I'll call it eastish. It's really what came out of some discussions between myself and Dr. Berman and Zemek was, could you talk about that, essentially the Alberta CHEO pipeline that is a bidirectional pipeline, I think, in a lot of ways, and we'll be talking about that. And I'll be talking primarily about a lot of the work that I have done and collaborated on with members of your team at CHEO. And actually, I think I just saw Dr. Osmond's face pop up briefly, so I'm glad he's there as well. A big focus of today's talk, as Mona alluded to, is PERC, or Pediatric Emergency Research Canada, which really goes all the way from Vancouver out to St. John's. And at the moment, we've never been a more cohesive, unified network with stops all along the way in our smallest towns as well. I'll call them town cities, and sites that have actually not always been huge members of our network, but even Saskatoon, Quebec City, et cetera, where they have smaller pediatric sites, have been actually very active and productive in COVID research and other initiatives that we've embarked on recently.
Stephen, so just before you get started, I don't think we can see your slides. So I think you're sharing.
I did not. I forgot to do the screen. I did it earlier and then forgot to do it. Now I got to go back again. All right. Now do you see them, Mona?
Yeah, we see them well. Thank you.
Sorry. I had these graphics in there now. So this was my Energy East pipeline that I was describing. And then this is kind of a map of PERC and our member sites. So I apologize for that. I should know by now. The goals of today's talk really are to focus on a couple of things and to try to tell a cohesive story. One of them is about understanding the benefits of fostering research networks to leverage collaborative foundations to address research priority questions. And then how to generate the best evidence in several PERC collaborations, focusing a little bit on concussion, gastro, and COVID. But I'll confess today's talk is not about evidence. It's not about studies. It's studies as examples of where things can lead and how people can collaborate. And then the last part will bring us a little bit up to the modern era about where the value of all the work that we had done over the last 10 to 15 years through collaborations have led to current activities that are actually allowing us to partner with key stakeholders to sustain network activities and to really be positioned as a network to embark on future initiatives. So just some background information for those who don't know. PERC was founded in 1995 with the aim to conduct research designed to improve outcomes in children who seek emergency department care. Several of our founding members are on today's call, and I'll go a little bit more into that. But our real key important features of our network was that we were brought together to conduct research that required the enrollment of either large numbers of children or sometimes those that have small numbers of children as well, so rare diseases. But really the key element was that these were not feasible studies by individuals acting in isolation in their own institutions. And we also were hoping to bring together PEM leaders to facilitate a collaborative approach to study design, trial implementation, and research mentorship so that we could learn, help each other along, and actually lead to better studies in the future. So this is a picture of our first inaugural meeting. I was not here, but you might remember or see some of these faces. This is one team member that you would know. Here's another famous PERC individual, Dr. Osmond, and I believe that's Rhonda back there. And I don't think I'm leaving any CHEO people out. If I am, please let me know. But those are the three that I'm aware of in that original inaugural meeting. But you can see how small our network was at the time. We are now over 200 members attending our annual meeting, which has been going on even through COVID, although not in person. It's been virtual with actually very similar attendance numbers. In terms of our successes and network, we had very little, obviously, in the early days. On the y-axis are numbers, in blue is publications, which, as you can see, have really been going up incrementally and rapidly through the last 5 to 6 years, where we had over 30 publications as a network last year. Grant submissions have been consistently around 10 per year for the last 4 or 5 years, and grants awarded have been numbering around 4 to 5 the last couple of years. A little bit of ebb and flow over time, but in general, the trend is a positive one that we're very excited about. This is actually a bibliometric analysis done by a non-PERC member who looked at pediatric emergency networks in general. And as you can see, number one, I'm really excited that Canada is kind of in the center of this whole bubble, Canada being PERC to a large degree, very close partnering with the United States. And there are other networks out here as well that we partner with, as well as others in Spain, for example, through what we call Pediatric Emergency Research Networks, which is a network of networks. But if you actually look a little bit at some of the topics that really are key focuses for PERC and some of our strengths, we've got bronchiolitis, we have brain injuries, and then we have my focus primarily being in gastroenteritis and dehydration. And then when you look at bubbles, you can see how closely aligned Amy and I are. We actually live close to each other. And while Roger doesn't get his own bubble, he actually, I think, is this one right over here. So we actually are very closely aligned. It's the way these systems and software work. So what you can see also is how these bubbles all congregate with groups close to each other and a lot of internetworking between the different investigators across the networks, which really is the success of kind of taking PERC and then having us connect to these broader networks. This is PREDICT, which is Australia, New Zealand, and this is our US colleagues primarily. So where did PERC really, learn and get, grow up as a network? It really was through the work of Dr. Osmond, who in 2001 launched what is well known as the CATCH study, the Canadian Assessment of Tomography for Childhood Head Injury Study. And this study, which actually involved 10 of the PERC sites, which was really a large initiative at the time, Ultimately published in CMAJ, identified key factors that are high risk in children who have a significant head injury. And it really was used to help us clearly identify who requires a head CT. You know, it's really hit prime time. When you get yourself your own MD Calc website that is now used globally by people to assess children in pediatric emergency departments. While Martin was taking his time writing up this study, Amy moved forward with PERC's real first, not Amy, Kenneth Bjornson out in Calgary, moved forward with our network's first RCT, which was a single dose trial of dexamethasone for children who have mild croup. So this one was conducted in 2001 to 2003 at 4 sites, so a relatively smallish multi-center RCT. But what this study proved, which is something that we're all doing and I think universally adopted now, is that dexamethasone is an effective treatment for children with mild croup in that it reduces cough and recurrent primary care visits. And that this approach is an appropriate one to children who present with a syndrome consistent with clinical croup. And obviously published in the New England Journal of Medicine. So really demonstrating the success and a primer for future studies within our network. While that was going on, I was actually living in Chicago and working on my own in isolation, still doing single center RCTs, but getting my feet grounded in gastroenteritis research. And I did a study there looking at the use of single oral dose Ondansetron to children who present to the emergency department with mild dehydration to moderate dehydration with acute episodes of vomiting. And what we found in that study was that similarly, administering a single oral dose in the emergency department was effective at interrupting the vomiting cycle, promoting oral rehydration therapy, reducing the use of intravenous rehydration, and thereby, and with no significant adverse effects and no increase in return visits. And that this therapy actually, once again, has become quite widely adopted as a standard of care therapy. But, at that time, I was relatively, I'll confess, unaware of PERC and its members, and had very few connections at that point in time to the Canadian landscape. However, what happened shortly after that, or actually right when that article was published, I moved up to Toronto, which then linked me more to the PERC network. But also similarly, Amy had to one-up my single center study and go with an 8-site study that recruited children between 2004 and 2007 into one of the landmark studies in the bronchiolitis world, which was a trial of epinephrine and dexamethasone in children with bronchiolitis using a factorial design, which showed, and we all know the results, that it is effective despite the analyses that were encouraged, endorsed, and supported and required by New England Journal of Medicine to adjust for the multiple arms in this study. But nonetheless, this really has led to a lot of subsequent investigations, research, and our current ongoing trial within the PERC network, which I'll come back to in a little bit. So once I moved up to Toronto in 2006, that is where I realized the value, importance, and strengths of the PERC network, and decided that I needed to start getting involved in those activities. And that's led me to significant number, extensive and ongoing collaborations with numerous CHEO investigators. And to date, I just did a quick search the other day to try to quantify the number of collaborations and joint publications. And Amy and Roger are in a tie with 30 each with me. Dr. Farian has 15 and Dr. Batt has 5. And really, it's been a pleasure working with all of these individuals and members, both as a co-investigator on the studies they are leading and as having them as co-investigators on projects that I have been leading as well. But I will say, so my first PERC study, which Amy was the senior author on, and this was published in 2011 in Pediatrics. And as I moved to Canada and started to understand the PERC network, I wanted to do further research in the field of gastroenteritis. And although that first study was published in the New England Journal of Medicine, I realized there was a paucity of groundwork and foundation for the conduct of future RCTs in the field. And what I had learned from PERC is that you need to do the background work to succeed at the CIHR level to get grants. And so through discussions of trying to understand gastroenteritis in the Canadian landscape and model on some of the early bronchiolitis work that had been done in the PERC network by Amy, she said, well, why don't you just do a prospective cohort study of pediatric gastro with no money? And I said, really, we can do that? And she's like, yeah, the PERC network's amazing. We can do that. And so literally went from encouragement, support to actually having the PERC network participate in the prospective assessment of practice pattern variation across the country study, which included Dr. Bhatt as well, who was not a CHEO at the time. But this study really formed a crucial foundation, learning how to collaborate and work as a team based on the fact that we think it's the right thing to do. So we did this study across the country, and we showed a couple really important things. On the bottom right here, you can see we showed dramatic variation in the use of Ondansetron in blue, which kind of peaked at some sites close to 40%, almost 0% at some sites, and then intravenous rehydration, where some sites, over 60% of children were getting IV rehydration at the time, whereas others who also didn't use Ondansetron were down to 5%. So we realized there was a lot of variation. We also looked at the volume of IV fluids that were administered, and we actually found an interesting correlation between sites that more frequently administer intravenous rehydration are more likely to give higher volumes of IV fluids in kids with gastroenteritis who are given IV fluids. But this study really provided a lot of the key data that has led to a lot of all the subsequent research I've done in the field. One of the key things that came out of this is an outcome score. So there was existing already what was called the Vesakari score, used primarily and developed in Finland by Dr. Vesakari and Dr. Ruska for kids with rotavirus diarrhea. And one of the elements of the score was percent dehydration, which really didn't make much sense for use in the outpatient setting. Number one, because I think, as we all know, we are very, very poor at assessing percent dehydration. And number two is that we don't see most kids ever again in person. So if we wanted to do outpatient research in gastroenteritis and not see the children again, we would need to come up with a modified score. And so what we were able to do is replace percent dehydration by future healthcare provider visits and reevaluated and validated the score using test diagnostic and characteristic properties, and really found that this score performed very well. One of the key things, because there isn't a lot of gold standards in the field, is that we were able to look kind of at the impact on life for kids. And we looked at absenteeism from daycare and kind of on the left here, and then in the darker purple, caregiver absenteeism from work. And as the score went up, because we actually were able to break it into three components of mild, moderate, severe based on total score, all three of those components went in the direction that kind of we would expect with increasing diarrheal severity. And so this score is one that I still use today and has become a very, very popular score, and really could only have been done, evaluated, and studied in the context of the PERC network and that first study that we did. One of the other things that I did in the early days was a survey through the PERC network. So the PERC network is doing several surveys, usually about 3 to 4 surveys a year of members. And actually this survey was of PERC members, but I also partnered with a group that I know in the US and worked very closely with called the Pediatric Emergency Medicine Collaborative Research Committee. They're actually an unfunded, primarily unfunded group that works under the auspices of the American Academy of Pediatrics. It's kind of their research arm within the field of pediatric emergency medicine. And I also partnered with CAPN, the Canadian Association of Pediatric Nephrologists, to do this survey. And what we were interested in doing, once again, is gathering some important baseline data related to the management of children with Shiga toxin E. coli infection. And so what we looked at was PERC on the left, the PEM-CRC, our US colleagues on the second to left, CAPN on the second to right, and obviously differences between groups on the right-hand column. And what we found were dramatic differences, particularly between the nephrologists and the pediatric emergency medicine physicians. But, and I'm not going to go into this disease too much, but really of interest and note at the time when we did this survey, if you had a child who had Shiga toxin E. coli in their stool, had progressed through the acute illness phase, which is marked by diarrhea, often followed by bloody diarrhea, but they can then go into a quiescent asymptomatic phase before going on to develop HUS in 15 to 20% of children who are infected by E. coli 0157. What we found is in this group of children, although there was some cohort study evidence of proof that if you give IV fluids and prevent dehydration early on in the course of 0157 infection, you can reduce the likelihood of requiring dialysis. We found that very few, if any, Canadian and US physicians would administer IV fluids as treatment when that STEC result comes back positive. Similarly, while slightly more within the nephrology group, they are not using it very much at all. And this study, along with the next one, has led to some current work, which I'll just briefly touch on. So this next study was another unfunded study that we did through the PERC network as well as the PEM-CRC, which was to look at children with STEC infection presenting to our member sites and to try to identify predictors of hemolytic uremic syndrome and the need for dialysis in these children. And what we found was that, and this is always, I find, very sobering data, of the 927 STEC cases included in our study, only 4% present with HUS. So that's kind of the good news, which means we have an opportunity before HUS presents to theoretically intervene, although we have very few, if any, true studies with evidence of benefit at this point in time. But among those without HUS, interestingly, a large number are admitted. So 41% of kids are ultimately hospitalized. And of these kids who are admitted who don't have HUS initially, 25% go on to develop HUS. So quite a high percent. Amongst those who are discharged, we didn't have any data on those who did not return. But amongst those who did return to the ED, and that's about 40% of those kids who are discharged, the HUS rate was also 17%. So there's a very high risk of HUS in the kids that we manage as outpatients who we think are okay and who do not have HUS at that early first initial index ED visit. The other sobering part about this data is that, and these are some of the laboratory parameters that were looked at that index visit. And what you can see across the white blood cell count, hematocrit, platelets, creatinine, serum sodium, there really is no significant difference between groups, even though the p-values were significant. When you look at these violin plots, the vast majority of children overlap between those who went on to develop, HUS on the right, and those who did not on the left. The one parameter where, although we did not have this on the vast majority of our children, when we did have it, as you can see, lactate dehydrogenase was dramatically different between groups. And that is actually something that I now encourage people to look at in the early days when evaluating the presence of microangiopathy or hemolysis in children with Shiga toxin E. coli infection. But what this work, all of it unfunded, going on through the PERC network, including at CHEO, has done is led to a current NIH grant that is funding a 26-site cluster crossover RCT, funded both by CIHR and NIH, going on at 4 Canadian sites and 22 US sites, evaluating whether hyperhydration in the early phase of children with high-risk STEC infection can reduce the incidence of HUS and development of or requirement for renal replacement therapy. So CHEO is actually not a site in that study because you luckily do not have a very high incidence of STEC, but it is going on at 4 Canadian sites and launching recruitment in September. So the other thing that I did through the PERC network where CHEO played a key role and actually was our top recruiter was a multi-center trial of a combination probiotic for children with gastroenteritis. So in this study, we enrolled children who had a minimum of 3 episodes of diarrhea in the preceding 24 hours. And we randomized them to either take twice daily a combination probiotic product of Lactobacillus rhamnosus combined with Lactobacillus helveticus for 5 days versus placebo. And what we found was, and our primary outcome actually of this study was the modified Vesicari scale score that I mentioned earlier. And what we found using that score as a dichotomous measure, looking at moderate to severe disease following the intervention, was that there was no difference whatsoever between groups. We further drilled down, as you can see here on this figure on the right, with the probiotic in the lighter blue and the placebo in the darker blue. We looked at the mean number of episodes of diarrhea per day. And as you can see, there really is no difference between groups. The other thing that we looked at was the mean number of vomiting episodes per day between group. And while it was slightly higher in the probiotic group on the day following the emergency department visit, there really was no difference subsequently. So we concluded that there was no evidence of benefit associated with probiotic use in children with acute gastro. I similarly did actually a parallel study in the US using a different probiotic agent and published in the same issue of the New England Journal that found essentially identical results of no benefit associated with probiotic use in these children. One of the things that our PERC network is doing increasingly is looking at translational research. And so what we did with this Canadian study was, in addition to doing the traditional RCT, collecting patient level data, we actually collected stool specimens. And we did two main studies with these. The first one that we published is actually collaborating with a virologist up in Edmonton, is we were able to calculate the viral load in stool. And what we were able to show, we were interested in evaluating whether giving probiotics more rapidly leads to a decline in the stool viral load over time. And what you can see is in the black is the placebo, in the red is the probiotic, is that when it comes to, and on the left, this is adenovirus, the viral load just declines almost identically between the two arms. On the right here, this is norovirus, and I have a third curve for rotavirus, which also similarly shows nearly identical reductions in the stool viral load. So kind of giving more of a pathophysiologic look at clearance of the infection in children administered probiotic versus placebo, to see if maybe we're missing something on the clinical side that is relevant on the more basic science side, and we found no difference. We similarly did another study where we looked at IgA levels in the stool of children. One of the theoretical mechanisms through which probiotics work in children with acute intestinal infections is through promoting mucosal immunity and the secretion of secretory IgA. And we actually similarly showed no difference between study groups in their IgA levels in stool. And that study was done collaboratively with Dr. Phil Sherman at the Hospital for Sick Children in Toronto. So I'm going to switch gears a little bit now and move into the next era kind of PERC research, which was the emergence of the concussion epidemic, and with the research there being led by Dr. Roger Zemek. And I'm sure everyone at CHEO is well aware of the clinical risk score for persistent post-concussion symptoms, or the 5P study in children with acute concussion. And so Calgary was very happily a partner in this study, which included obviously many people from CHEO. And what we did through this study was we prospectively enrolled a very large cohort of kids. And this approach to prospective cohort recruitment, kind of initially originating from the CATCH study, but much more detailed in the 5P study, has also been a mechanism that we've been able to replicate through the PERC network in several other studies. But through the prospective collection of data and outcomes longitudinally on these kids, we were able to identify those who developed the post-concussion syndrome, and we were able to look and develop a score. And actually the methodology, this was actually a great partnership. I learned a lot through participating in this study and working with Dr. Barman, the statistician, the biostatistician at the time on this study. And as you can see on the right here, the ultimate score had improved characteristics, far from perfect, but improved characteristics on the ROC curve, better than physician prediction alone, obviously, which wasn't much better than flipping a coin. So this was a dramatic advance and one of the early advances in the field of concussion research. This led to another study led by the CHEO group as well, looking at the association between early participation in physical activity. For those, many of you will recall that in the early days of concussion work, we really restricted physical activity, use of electronic devices, et cetera. And that whole approach has really changed, and we're much more amenable to early resumption of some activities in moderation. And what we found actually, and this was led by Dr. Gruhl, is through using a propensity design, which once again was the first time I'd been involved in using that type of approach. And I have since then used it in several of my own studies, is that among participants who were included in the original cohort, physical activity within 7 days of acute injury was associated actually with a reduced risk of the post-concussion syndrome or persistent post-concussion syndrome. And that has led to kind of changes, as well as a subsequent RCT led by the CHEO group as well. And what you see here a little bit is what, for those who aren't familiar with propensity designs, is that it actually allows you to take groups that before matching are very different in their propensity to do physical activity. And then after matching, you actually have groups that are very similar in their likelihood of doing physical activity. So you can then actually compare and analyze those kids and the impact on the outcomes. So one of the next key milestones in the growth of the Pediatric Emergency Research Network was an initiative led by Dr. Terry Klassen, who's based out of Winnipeg, which really served here, as you can see, as the data coordinating center for this work. And what we've done is that we actually applied to a CIHR call for innovative clinical trials, and we put together an innovative pediatric clinical trials network, which brought together many institutes who played different roles. So TREC is a Center for Knowledge, an NCE, a National Center for Excellence in Knowledge Mobilization, and then as well several of the different research institutes across the country to give different strengths to our team, partnering with PERC, KidsCan, which is a trial network, as well as at the time MyCERN, which was kind of nascent in its evolution. But what we did actually is we actually were able to do and have 4 studies as part of this umbrella network, one being led by Stollery, looking at pain in children with a musculoskeletal injury. I am currently leading a study on Ondansetron use, which I'll come back to briefly. CHEO over here is leading, CHEO over here is leading the BiPED study, which is a follow-up study of Epidex in children with bronchiolitis. And then London or Children's Hospital of Western Ontario is leading a study looking at dexmedetomidine in children undergoing pediatric procedural sedation. So the dosage study, once again, goes back to using the same score that was derived in 2010, 2011, and that remains the primary outcome and kind of really the best one to date in children with gastroenteritis. And what we're doing with this study is essentially a follow-up to that early New England Journal of Medicine study where we gave a single dose, and we're actually now looking at whether children with gastro who get a dose in the emergency department should go home with multiple doses of oral Ondansetron for use at home. So this study is using kind of a couple innovative approaches. One is that it's not standardized dosing at home. It's actually PRN dosing left up to the caregivers and child's discretion of whether they feel they're having significant nausea or ongoing vomiting and warrant taking an additional dose of the medication. The other piece that we're doing is we're working with the methodologists to do a discrete choice experiment to identify their values of the different outcomes in gastroenteritis. And then we're going to derive a new score and model based on the values of the caregivers related to outcomes in children with gastro, and rerun the entire analysis when we've completed this study using the discrete choice experiment model as our primary outcome and see if that changes anything as well. The study is well underway, having recruited nearly 50% of the cohort, or 500 children out of over nearly 1,000 that we plan to enroll. Obviously, it was challenged through the COVID pandemic, as were all of the subsequent studies that I'll be discussing. But we have subsequently emerged as strong as ever, and recruitment has really been picking up over the last 6 to 8 months. So similarly, Amy has been running a randomized controlled trial comparing epi and dex to placebo in the treatment of kids with bronchiolitis to follow up on some of the challenges and concerns related to the original study. This study is going on at the same sites that we mentioned, but in addition, Amy was able to recruit sites in Australia and New Zealand to participate through our partner Predict network, and that has been helpful as well. And recruitment, once again, did struggle through the COVID pandemic, but has been much better over the last 6 to 8 months and is ongoing. But I do need to kind of dovetail a little bit into the impacts of the COVID pandemic. I think we're all aware, beyond obviously the health impacts on everybody and the public health precautions and the impact on our day-to-day lives. But the academic world, COVID had major impacts, obviously. At an institutional level, non-COVID-19 research, such as dosage and the other spore studies, were dramatically impacted along with everything else. And obviously COVID-19 research had to be supported at an institutional level, and I'll come back to that. There were a lot of changes in how we socialize at work. So workforce health and safety became important. Social distancing and doing grand rounds over Zoom has become the norm, and hopefully won't be that way for much longer. And obviously there's been a big impact on the education and training of our residents, fellows, and medical students as well. At an individual investigator level, it's had major impacts, from our impacts on our family life to publications to how do we maintain our critical research infrastructure, our team members, as well as our ongoing activities. How do you plan and write grants in the era of COVID, where number one, there were constantly emerging COVID funding opportunities. And it was also hard to get around to have time to work on other things. We changed our mechanisms of communication. We often no longer have our teams, our individuals, our PERC network gatherings have all changed. And so all of this has really impacted all of us in many ways that we should not ignore. But it did also present, from an academic perspective, some opportunities. Really, our PERC network actually had our last in-person meeting at the end of January of 2020, at which point in time COVID was already spreading, had moved beyond the borders of Southeast Asia, and had already been to Italy that we were aware of, and probably obviously North America probably, but we were unaware of it at the time. And at that meeting, the PERC network realized what may be on the horizon, and was actually, because of all these strong network and ties that we had existing, we're able to really quickly pivot and be ready for this global pandemic. And the first thing that we were able to do or publish, which emerged from what we saw happening in the emergency departments, was that the emergency department visits, and what you can see here is 2018, 2019, and 2020 in the different little boxes, and they kind of go here with 2020 when it comes to emergency department visits over weeks number 1 to 20 of the calendar year. All of a sudden, around week number 10, emergency department visits died off. And they went down to approximately 1/3 of our normal. And this was kind of an unexpected, unusual phenomenon. And clearly, what has come out of this has been a lot of changes, obviously, to planning and volumes. And I believe CHEO is going through the same challenge we are right now in Alberta, which is that our volumes are dramatically higher than usual, with a lot of very ill, acutely ill children, and our biggest wait times we've ever had in recent memory. And some of that may have been due to the fact that we saw so little virus and viral illness for the past 1.5 to 2 years in children. But what this also did is it allowed us to kind of look globally at the effects of COVID on children. And so through the PERN network, which is the Pediatric Emergency Research Networks, of which PERC is a member network, it is essentially a network of networks that includes sites in South America, Europe, Australia, New Zealand as well. We were able to put together a prospective cohort study with some funding from CIHR to look at children and follow them longitudinally over time, both kids who were SARS-CoV-2 positive who presented to pediatric emergency departments, as well as children who were SARS-CoV-2 negative. And a lot of this actually was built on the foundation of an existing study that Amy was involved with, which was actually what was called the PERN pneumonia study. And that study was looking at pneumonia in children around the globe, enrolled prospectively with no funding. We were able to supplement and build on that with this study, and you really use that existing platform and connections and ties to rapidly launch this study. So what we did in this study is we enrolled children on day 0 after they present to the emergency department. On day number 1, we would contact them by phone and collect epidemiological data, demographics, medical history, current illness, any testing done in the emergency department, as well as looking at clinical care and outcomes. And we follow them through a hospitalization should that occur. And then on day 14, we did a follow-up phone call to look if they had any revisits to the emergency department to look at outcomes. On day number 30, we did a chart review. And then on day number 90, actually, the postdoc fellow who I had who was heavily involved in this project, Dr. Anna Funk, suggested, let's look at persistent symptoms. And this was way back in February of 2020, she said that. And so we actually built in a 90-day follow-up phone call, and we have a manuscript that is nearly accepted looking at persistent symptoms in children with COVID infection coming out shortly. What we did publish to date, though, is that we looked at children who were tested in emergency departments and looked at predictors of severe outcomes in these kids. So we enrolled in total over 3,200 children who are SARS-CoV-2 positive. Of these kids, 79% were discharged from the emergency department. And of those who were discharged, severe outcomes still occurred, but uncommonly, and only occurring in 0.5% of the children, and 0% died. If we looked at the children who were hospitalized acutely, which was 21% of our sample, including 13% that were admitted directly to the ICU of those who were hospitalized, we found that severe outcomes occurred in nearly 14% of children, and 4 children, or 0.6% of all children hospitalized, died. When we looked at predictors of severe outcomes, we saw, interestingly, that Canada was very low. The odds ratio, the adjusted odds ratio of a severe outcome was 0.11. And I believe a lot of that relates to our very broad testing strategy in Canada at the time, relative to our other partner countries, such as the United States, which served as a reference point, where in the first year of the pandemic, particularly the first 4 to 6 months, they had very limited testing, mainly restricted to kids who were hospitalized, and in some institutions, restricted to those who were admitted to the intensive care unit. We found that age, so older children, those aged 5 to 10, and even more so those aged 10 to 18, were more likely to have a severe outcome. This may relate to the fact that early on, some children, particularly the very young, were hospitalized, even if they actually had very little or mild symptoms, but primarily for observation, whereas the older kids were the more severe kids who were hospitalized. Some of them also may have had MIS-C at the time. Kids who had chronic conditions were more likely to have a severe outcome, those with a previous episode of pneumonia. And the other piece of note is that kids who were sick 4 to 7 days had an odds ratio of 2.2 for a severe outcome, reflecting the fact that if you came in very early in your symptom course, you probably still had mild illness and it was more a bit of worry, whereas those kids who came in later probably were reflecting greater symptomatology and evolution of disease. I'm just going to wrap up by touching on 2 ongoing studies that we are doing currently in the PERC network. The first is where Health Canada reached out to our network to evaluate the Abbott ID Now device with the hope of being able to use that in non-healthcare settings and to be used or utilized by lay personnel. So we actually designed a buccal swab study where the caregivers or child, if they're old enough, are doing self-swabs or caregiver swabbing their child of their buccal mucosa, and we are running it on the Abbott ID Now device, including in CHEO. This is one of our 15 sites. Actually, every single site in Canada is involved in the study. We have recruited over 1,300 kids to date, and we'll be able to provide our analysis to Health Canada shortly, although we are going to continue recruiting to our final sample size of 2,800. But this study is a classic example of how during COVID, predicting certain metrics is very challenging. When we designed the study, we had about a 1 to 3% positivity rate. This was prior to Omicron, but as we all know, the positivity rate in the current era of Omicron in emergency departments actually is closer to 20% across the country. So we've actually been able to recruit a lot more positives more rapidly than planned. The other study that we've been doing is funded by PHAC, which is a COVID ED surveillance study. And with this study, we are focused similarly to the PERN COVID study with 2 additional spins of what we're able to do, which is to look at variants of concern and their impact on children acutely, as well as looking at long COVID. And we're looking in this study out to 1 year post-ED visit, and we're able to integrate the different and varying variants that have emerged over the 1.5 years of recruitment to see its impact on children. So in summary, I'd like to just wrap up by really highlighting the strength of CHEO, their investigators, and the collaborations that I've had in the PERC network has had with them, and that how these have led to major advances in the field of pediatric emergency medicine, as well as our existing and ongoing activity. I really truly believe for the trainees on today's call, if there are some, that pediatric emergency medicine and our collaborations fosters an amazingly diverse milieu for research, and it's an amazingly collaborative setting for people to embark on their careers. And really for individuals across the different specialties, the importance of having a strong and cohesive network and wanting to work with your colleagues, a strong level of trust, and how that can lead to an amazing array of opportunities. Would like to thank the different funders who've made some of this work possible, and I'd be happy to answer any questions.
Wow, thank you, Stephen. That was a real whirlwind. You could have even said so much more. You've really highlighted some of the key accomplishments in pediatric emergency medicine and really showed the way for the future. So thank you for that. Looks like we've got our first hand up, and that goes to Dr. Jason Berman. Go ahead, Jason.
Thanks, Mona. For some reason, I'm not able to put my camera on, but Steve, thank you very much for that tour de force. Really wonderful. Many of those studies I was aware of, but there were also numerous ones that I was not aware of. And one of the things that I think we all strive to do in all of our research programs is to have an impact. And certainly you've had that in spades, not just on your colleagues and trainees, but of course on numerous patients and families, and how things are done differently across Canada and beyond in the emergency room. I was glad to see on your summary slide that you highlighted collaborations and networks. And while you made it sound so smooth and easy, I know that these things are never that simple. And I think, again, for some of our trainees or junior investigators on the call, that may seem really daunting, how you start a network, how you collaborate with multiple different sites to get the sample sizes and numbers of patients you need. And so I wonder if you could speak to that a little bit, the trials and tribulations, maybe some lessons learned. And also, as you're aware, and many folks are aware, through the CHEER program, there's efforts to harmonize pediatric research ethics boards across the country, and whether you see that as being something that would be helpful, or is that an additional challenge?
Yeah, for sure. Well, first of all, I was fortunate enough to join the PERC network after it had gone through probably some of its more challenging years, and able to build on the work of some of the real founders, Dr. Osmond, Dr. Klassen, Dr. Johnson, who really, I think, led that network through its early infancy, and were able to go from that picture where I showed you of 16 people, I think it was, or 18, to over 200. And I think, I feel the strength of networks is the individuals involved, actually. So the ability to collaborate, to work together, to have trust is so important to networks, to know that I think trust can't be, having gone through some networks where it's not always there, when you have trust in people, they will support you. They know that no one's going to try to one up you, that no one's going to try to leave you out of a study. And I think the PERC network, even the fact that the PERC network is kind of willing to do unfunded stuff to try to support people, the amount of, and I will say it's right now, the current chair of PERC is Dr. Zemek, as hopefully many of you know, and having led the network for 4 years as well. And it's actually, it's a labor of love. You don't do it for the accolades or the pats on the back. It's with PERC, we actually have 4 years as a vice chair, 4 years as chair, 4 years as past chair. It's a 12-year commitment. And it really takes fostering the young individuals in the network. So there really is a lot involved in it. The other thing I will say that I feel, truthfully for me, is I feel a responsibility for sustainability. Not just myself, but I hope all of the members do. And I try to share that. And, one of the things is feeling like we do need to bring in increasing funding all the time, which is a bit of a challenge. That's one of my bigger worries, is where we're at in 5 years. I want to leave our junior investigators better off than when I entered the network. are there challenges? Multi-center research is extremely challenging. And actually, the biggest challenge with multi-center research generally are the administrative headaches, often more than the academic headaches. Most of the site investigators want to be involved. Most of them want to do the right thing. Unfortunately, sometimes, the legal piece can hold things up extensively, although I know many of us are working on that. The ethics piece can be a challenge, as you alluded to, Jason. I do think, harmonized ethics reviews are happening and developing. I personally, I don't think we're going to get to one across the country, but we may have kind of a little bit of a patchwork, with CTO being one. Quebec is doing their own thing. And out west, we're working on a partnership right now between BC, Alberta, Manitoba, and Saskatchewan that'll come together hopefully very soon, where we have a single one. So I think we're getting there on that front for sure. But I honestly don't think ethics is usually not the contracts actually probably what delay things the most, more than anything with a lot of these initiatives. Data quality and learning for some sites, our smaller sites aren't always as used to doing the studies, but I think that's our own internal responsibility as a network to help bring them up to speed and make sure they're involved in as many studies as we can, which I think actually COVID has really helped us do that, and value those smaller sites has been really important. But trials and tribulations. I think you saw all the successes, or not all of them, but some of the success I point out there. Major challenges. I'm going to confess, they're never easy. I mean, COVID has thrown wrenches at us, and we've been timelines, but I think as long as everyone's committed to doing the study and doing the best they can, eventually it'll work out. And I can't say there's any study that I've done at a multi-center level that I wish I hadn't. Have there been some studies where some sites haven't been able to deliver? Yes, and that can get a little bit more challenging, but we need to have honest dialogue. And I had to pull one of the sites out of my probiotic study, for example. And I think that was life, and we had to do it, but it was honest, open dialogue as to expectations, reasons, and decision-making process. And I think that is the most important thing that one can do, is transparency also within the network. I think our leadership within PERC really tries to be transparent to our membership, so there is nothing opaque. And the other big thing that we do in our network is we are very open to publication by anybody. Meaning, the number of studies Roger has done off of his concussion work and the number I did off my gastro work is only because we actually have really went and wanted others to publish with our research, and we try not to hold it close to our chest and keep it to ourselves. So I really think it's about sharing and success across the network with all members.
Thanks for that.
That's a fantastic answer, Stephen. You really covered so many important issues there. We have a little bit of time left for questions or comments if anybody else has a question for Stephen. Go ahead, Roger.
I was trying to click, but I figured my camera's on, so it's easier to raise your hand. Congratulations again, Stephen, on all the tremendous success. We all don't know how you find the time to do so much. It's incredibly impressive, and you're being still so tremendously practice changing with all your ideas. So congratulations on that. One of the things I thought may be helpful for some of the attendees as well, generating the niche research, publishing it in the journals is only one step. Making sure it gets into the hands of providers, and you talked about Martin's getting things on MD Calc, but perhaps even introducing in a bit more detail some of the partnership we have with TREC. I know Mona and others on the call are very involved with TREC, and talking on that, I think, has been quite a nice symbiotic relationship for PERC, and making sure the knowledge is translated, and the next ways that we can always make sure that it's not just the academia that does it, but the concept that there's a lot of emergency departments across the country that are community-based, where they're non-pediatric emergency staffed. And if you have thoughts on that, and I think that has actually helped our grants as well, saying it's not just we're going to study this, it's going to get into the doctor at Pembroke or the doctor at Smith Falls, who also is going to treat that child in the community emergency.
Yeah, no, well, actually, I'm going to comment quickly on your first point about productivity. I actually learned, I think, from Terry Clausen a little bit when in some early conversations, and I try to learn from a little bit from everybody along the way, was in discussions about hiring good personnel. So, I have a fairly large team, which makes my, I didn't put up the picture at the end, but the work I do, I couldn't do without amazing support from the team members that I have here, both physician, but mainly I'm referring to my non-physician research program managers, research assistants, research coordinators, statisticians that I collaborate with, who are so crucial. So treat all your staff incredibly well, pay them well, and make sure you can hold on to them, because they are the secret sauce that makes all of this work. And actually within PERC, we have a very strong presence of our coordinators who have their own sessions, they have their own meetings, and we really try to promote, and they're a core fundamental part of our gatherings. So really, really important that way. The other piece on the knowledge mobilization front, I'm going to confess that's probably not my strength. And I think we can't be everything. But I do try to partner with knowledge mobilization networks. We're fortunate one of the spinoffs from PERC in the early days when we were actually talking, this came out of a sustainability talk of, where are we getting our next funding, our next grant? And several members of our network, Terry, David, Lisa Hartling, started thinking about a knowledge mobilization network, because CHR had a call coming up, along with Mona as well, and really put together the TREC network, Translating Emergency Knowledge for Kids, which has been really fundamental and really leading the way. So I know Mona has done many of the pathways that many of you have seen across Ontario. We've kind of adopted them a lot in Alberta as well. And that has been instrumental. But, I think it's a part of our grants, but it is a very close partnership with PERC. But I think it's also realizing, to me, I truthfully, I'll confess, it's not my strength. And you can't do everything, and you need to have people who have expertise in that realm, because it's a different field, it's a different niche, it's a different market, and you can't do it all. So I think that's another realization, and just accepting that fact and reality, but then knowing who to go to. I'm not a big social media person, truthfully, as well, but I have partnered and tried to utilize TREC, PERC, my universities to do a lot of the social media. And I will say, through a lot of both the publication and the COVID pandemic, there hasn't been a shortage of media and getting knowledge to the public, which has been really important. So actually my focus, truthfully, is really a lot, almost, I would say, less on getting it to the medical community, because I think that'll get there, that'll happen a little bit when it comes to the one-off articles, not so much the pathways, but the articles. Whereas getting it to the lay public and translating the right message, like what's the message we're getting out there right now about the 7 cases of liver failure at sick kids? That's what we need to do, really, I think, as a community, whether it's academic or clinical, is we need to make sure the public is getting the right messaging about the different things from faces and people that they trust. And I think that's a really important point that we need to make sure we're doing in the pediatric world, not just emergency medicine, but in general.
Great. Very well said, Stephen. Thank you so much for sharing all your knowledge and experience and expertise with our group here. I really wish the future success for Pediatric Emergency Research Canada and all these great networks, and long live the pipeline. Thanks again. Have a wonderful day, and thanks for waking up early to present to us.
My pleasure. Thanks a lot, everyone, and have a great day. Thank you for the opportunity, Mona and Jason, Roger.
Okay, bye,
Bye-bye.
everyone.